Let us move on to the next group of disorders, which is Papulosquamous disorder. It includes, first we will see psoriasis. It is chronic T-cell inflammatory disease involving skin and systems that is associated with metabolic syndromes. Pathogenesis. Here, hyperproliferation in the epidermis is seen. The epidermal transient time, which is normally 28 days, is reduced to 3 to 5 days. Dermis. Here, inflammation is seen in interleukin 17, 23, and TNF alpha can be seen. Chronic plaque psoriasis or psoriasis vulgaris is the most common type. It includes red, scaly papules and plaques. Scales are silvery white and it is present in the extensor distribution. Auspit sign is seen here. Let us see how this is performed. A glass slide is used to scrape psoriasis lesion. It is Grottage test. Here, silvery white scales, bulky membrane, pinpoint bleeding spots are seen. Koebner's phenomenon is seen here. That is also known as isomorphic response, which is similar morphology of scales over the trauma line is seen. Now, Koebner's phenomenon is of two types, true, which is immunologic, and pseudo-Koebner's phenomenon, which is autoinoculation. True Koebner's phenomena is seen in psoriasis, lichen planus, and vitiligo, whereas pseudo Koebner's phenomena is seen in viral warts and molluscum contagiosum, and rare causes are lichen nitidus. What are the nail findings in the psoriasis? Here, pits are present. These are coarse, irregular, and deep. Subungual hyperkeratosis under the nail plate is seen. Distal onycholysis, which is separation of nail from the nail bed, is seen. And pathological nail finding is salmon patch or oil drop sign. Here. Next type is pustular psoriasis. Its most important trigger is sudden stoppage of systemic steroids. Here, lakes and sheets of pus can be seen. Types: acute generalized form, which is one Zombush type, and pustular psoriasis of pregnancy, which is known as impetigo herpetiformis. Erythroderma, it is also known as exfoliative dermatitis. Here, erythema and red plus or minus scaling is involved in more than 90% of the body surface area. Psoriatic arthritis, it is seronegative, and classical joint involved is distal interphalangeal joint. Histopathology of the psoriasis. Here, thickening of the stratum corneum is seen, which is known as hyperkeratosis. Nuclei is seen in stratum corneum, which is known as parakeratosis. There is collection of neutrophil in the stratum corneum, which is Monroe's microabscess. Stratum granulosum may be absent or decreased. Collection of neutrophils in stratum spinosum, that is known as spongiform pustules of Koch. All these features: hyperkeratosis in stratum corneum, parakeratosis, and Monroe's microabscess. In stratum granulosum, absent or decreased, and in stratum spinosum, spongiform pustule of Koch. There is Presence of dilated vessels in dermal papilla and elongated retiridges can be seen. Histological images of parakeratosis and Monroe's microabscess. Treatment includes topical for less than 10% of the body surface area involved, phototherapy for more than 10%, and systemic for more than 10%. First-line therapy in special situations like pustular psoriasis is acitretin, which is oral retinoid. Second drug of choice for pustular psoriasis is methotrexate. In pustular psoriasis of pregnancy, first drug of choice is systemic steroids, and second drug of choice is cyclosporin. Biologics, which is targeted therapy, blocks interleukin 12 and 23 is ustekinumab, blocks interleukin 23 is guselkumab, blocks TNF-alpha is infliximab, etanercept, and adalimumab, and interleukin 17 is secukinumab and exicuzumab. Let us see some of the previous year questions. Which is the only indication of systemic corticosteroids in psoriasis? It is impetigo herpetiformis, which is the pustular psoriasis in pregnancy. What is the treatment of choice for erythrodermic psoriasis? It is methotrexate. Erythrodermic psoriasis is pustular psoriasis, in which methotrexate is given. We are going to see is lichen planus. It is chronic immune-mediated inflammatory skin disease. Here important trigger is dental amalgam or mercury. Lichen planus, 6 P's we have to remember. Purple pruritic, polygonal, plain-topped, papules and plaques. These are the type of lesion seen. Purple pruritic, polygonal, plain-topped, papules and plaques. If magnifying lenses are used, reticulate lacy white patterns are seen, which are known as Wickham's stria. See, Wickham's stria. It is distributed over flexor surfaces. Here, true Koebner's phenomenon is present, and oral lesions include reticulate lacy pattern. Nail lesions, most common is thinning, and characteristic is pterygium present on the nail. In hair, scarring alopecia is seen. Thickened stratum granulosum is seen, which appears as wedge-shaped hypergranulosus. Sawtooth retiridges can be seen. Sawtooth retiridges can be seen. Wedge-shaped hypergranulosus. Cleft at dermoepidermal junction, which is Max Joseph's space, is seen here. And eosinophilic body, which is necrotic keratinocytes, can be seen, which is colloidal clavate bodies. Here treatment is steroids. Now let us see some of the previous year questions of lichen planus. The oral cavity of the young woman is filled with white lacy lesions, and her proximal nail fold has spread onto the nail bed, which is pterygium of the nail What possible diagnosis is there? It is lichen planus. Next question, or next we can say Paul is there are many variants of lichen planus based on the morphology and location. They are oral, nail, linear, annular, atrophic, hypertrophic, inverse, eruptive, bullous, and ulcerative, lichen planopilaris, lichen planus pigmentus, vulvovaginal, actinic, lichen planus, lupus erythematous overlap syndrome, lichen planus pemphigoids. Next topic is pityriasis rosacea. It is scaling of red color. Acute self-limiting eruption is seen here. Morphology is first lesion is herald patch or mother patch. Scales are colored scales and it is distributed over the lines of Langer in Christmas tree pattern. Next topic is pityriasis rubra pilaris. It is scaling of red color and of hair follicle. It is present around the hair follicles, follicular papules, and it is erythema plus or minus scaling of the more than 90% of the body surface area for erythroderma. Islands of sparing seen. See, this is erythroderma and islands of sparing can be seen. Thank you.